Hello, good afternoon, good morning. Welcome to our July Willis and Friends. I'm thrilled to have you join us again. As you know, we hold these activities monthly, and it's always a delight for me to have my friends, my colleagues, my thought partners with me. And as you know, our Early Relational Health Coordinating Hub seeks to advance relational health across child health, early childhood communities, as well as the movement building element of focusing relationally. All of this, of course, includes careful attention to racial justice, anti-racism, and health equity. And so I'm really thrilled today to have some dear friends with me. Let me first give you the context of what we want to talk about today. I think all of you know that early relational health is actually a broad agenda. It's a movement-making effort of focusing intentionally on the criticalness of those foundational relationships, that relational health element, and it's an all-in strategy. So it's not just the child health sector, public health sector, of course, but it's really broader to the early childhood systems, early care and education, those formal and informal systems that join families, but most of all, where families live is local, in communities. So in many ways, moving this early relational health agenda requires us thinking deeply about community engagement, about place-based initiative, and surrounding all of our efforts to support the relational experiences of young families. That's the part of the movement we want to talk about today. And I can't think of two greater and dear friends who've been with me on this journey and have their own experience of this space as Janice Grinnell and Dana Long. Let me tell you about each of them. First of all, Janice Grinnell is, I think we're kindred spirits, Janice. We met back when I was at Hearst. I think we met through Joe Walters, Institute of Child Success. You and I did a little dog and pony show, right, to the Institute of Child Success meeting down in, where were we, in South Carolina, I think?
Yes.
And we had a lot of complementary thinking together about moving this relational health work. And I've been really honored to know Janice, I think we have each other's speed dial numbers right available to each other. I often see things either early or late, but we share our excitement of this movement of focusing on the strength of families, deep with communities, and you'll get to hear a lot about that today. Janice has over 30 years of applied social science and public health experience, working in state and local policy and practice in early childhood. She's a research professor at UNC in Charlotte, a fellow at Yale, senior consultant to the Bridgeport Prospers you'll get to hear about. She's comes out of having worked in state government as a senior executive in child welfare, public health, developmental disabilities, and corrections. She served as the senior early childhood policy advisor to Governor Jody Rell, 2004 to 2009, really helped move this early childhood space work. And we'll get to hear about that journey. She resides both in North Carolina and in Connecticut. So Janice, welcome. I'm delighted you're with me. And then Dana, my dear friend, you and I also met when I was at HRSA. You and I first met around, I think, the Find Connect model. I reached out to you, and then you and I met. I then had the chance to meet you face to face when you came to DC for a presentation, and you and I immediately had a vision of opportunity. I then came to your resiliency clinic in Oakland, which was a joy to see your work, your people in action, meet some of your families and your staff. And I know Dana's work about the Pearls advancing pediatrics adverse childhood experience resilience study with the Pearls, and then the Find work, the Find Connect work, and then all the leadership work you've done in California, and now what we're doing together, right, around advancing early relational health, this movement making work. So it's just delightful to have both of you with me and for the conversation we can share together. So I thought it'd be valuable, perhaps, if we just start with each of you sharing, telling us more about yourself, how you've come about your journey, what brings you to this early relational health work, how do you think about place-based work in communities, just to get us started. And Janice, can I come to you first?
You sure can. So the intro was too long, but anybody who's on this listening to us now knows why I signed in as AKA Granny Janny, because this has turned out to be a journey for me that started when I was 22 or so. And I'm not going to tell you how old I am now, but it's significantly more than that. So what I'd love to do, David, is share with people two threads of me. One is the personal journey, which I will do very quickly, but it informs my professional passion and my annoying growth as an advocate in this space. So I do think that's a useful place to start. I can do it pretty quickly. And so here's the personal journey piece, and then I'll share the professional passion work through the Bridgeport Baby Bundle that you have been really a mentor and a guide and our North Star for the last 7 or 8 years. So personally, I was a military widow at the age of 22. I had one baby, a year old. I was 9 months pregnant. We were living in Japan. And my naval officer husband's airplane was shot down by the North Koreans. So that in and of itself is a pretty stunning event. I couldn't come back because you can't fly in the last month of pregnancy then. This happened, the reason that I share this is because this happened on April 15th, the year doesn't matter. My second son was born on May 18th, so just over a month. So this baby lived in utero inside me with the cortisol passing back and forth from me to him through the placenta. A kind of intrauterine trauma that nobody understood then, or that people didn't talk about then. And none of us had any idea that this wouldn't all just be wonderful when you got born, right? And that, of course, is not true. And it leads us to the work that you're doing now. I share this because I am, and so many of us are now focused on the period from pregnancy through the early years. And what I've learned on this personal journey has informed everything that I've done. In a sort of high level thing, we need to focus way more on maternal and family health early in life and early in pregnancy and early in our relationships, so babies have an optimal chance for early relational health, healthy births, and on-target development. I mean, that's the place where we end up in this. The second thing that I learned, and there are lots of side stories, as you might imagine, just like a spider web, I learned that this kind of trauma has a really long arm. You know, we talk about ACEs having a really long arm and racial injustice and discrimination having a really long arm. Trauma in pregnancy has a very long arm as well, and not one that is as well understood as maybe it can be. And it was certainly not understood at all when I began my journey. I think I told you, my doctor told me everything will be fine, just have chicken soup. Well, I did have chicken soup and it wasn't. So it sort of helped me be in the space. My son, my middle son, has struggled for years. I mean, he's a perfectly fine, successful businessman. He was in the Marines, obviously inventing a history that he did not have. But the fact that the struggle lasted so long for him told me a really lot about the biochemistry of that period, and also probably about my own mental health and well-being, trying to claw my way out of this trauma. And for me, that matches so much of what is the traumas are different, but so much of what is happening in the field you and I and Dana have been laboring in for years, which takes me the professional side, which I can do really quickly. I did my PhD in developmental psychology because I then knew I needed to be thinking about children and their families. And I worked in state government, as you said. For me, it was pretty much the back end of government. Like, why would you send a developmental psychologist to corrections, right? Why would you do that? Why would you send them to work in places that did institutional care for persons with mental retardation or child welfare abuse? Well, what I realized was that was about me finding my voice, because I couldn't really change the systems. It was the wrong time in all of those. Now, of course, it's the right time. And I wouldn't change any of those experiences. So to take us to, so number one, that's who I am. And my voice is there and it's annoyingly present. But I've had the experience personally and in systems, right? So I figure I have my badges and it's time to wear them. So AKA Granny Janny Talks. The work now that we'll talk about is just like what you said, all in. It's an all-in strategy at the community level, built by the community, focused in on these years, these early years. We are cradle to career and we're community impact. So we go through the graduation from high school, but we're really focused on the birth to 3, then the 3 to school, and we include kindergarten and then 3rd grade. So we use some of the national benchmarks, but we can talk some more about that. But it's definitely an all-in strategy in the baby space.
Well, Janice, that's, I mean, what an amazing story. It's, and makes visible your passion and your nothing's annoying, but rather clarity, voice and passion and leadership and understanding and personal knowing, which is what this work is so
No,
critical.
thank you.
Yeah, truly. Thank you. Dana, to you.
So that story, Janice, that you shared, it's so riveting. And I have so many more questions about what was it like when you first came back from Japan, and how did you get on track and have 3 kids and go to graduate school and get your PhD? I mean, you definitely are an amazing shiro, and thank you so much for sharing your story. So I came to the work. I am a professor at UCSF in our Department of Pediatrics, and I've spent my career within our safety net, our federally qualified health center in Oakland. Growing up, especially in a family of color, social justice was always a really important and central part of my life. Although we like to think we're very removed from history, sometimes I grew up with my father, who was essentially, his family were sharecroppers in a very small town in Tulsa, Oklahoma. And this notion of lifting your whole community up was something that was just part of my fabric and part of my DNA. And sharing his stories of what it was like growing up in segregated times when he wasn't even allowed to go to school with white people or use the same bathroom or walk on the same side of the street. I always knew that I was interested in going into medicine, but I needed to find my footing in that space. And so when I graduated from college, I actually was part of the first class of AmeriCorps, and I worked in a free clinic in Los Angeles. And I worked with peer educators. Granted, at the time I was very young, the same age as many of these peers, and they came from all walks of life, mostly young people of color who were either in gangs or trying to get out of gangs, teen moms. We had some homeless youth who were part of our peer education corps. And we spent the days literally walking the streets. We'd go to homeless shelters, we'd go to squats. We even went to some nightclubs and we'd pass out condoms at night. And it's fascinating to me to look back. That was now 30 years ago. And the work that I'm doing now is very much still related to that period of my life. When I came back to California after going to medical school in the East Coast, I wanted to work within a safety net. And so I found a home in Oakland at our federally qualified health center, where 90% of our families are families of color. 90% of our families are also at or below the poverty level. And the way that we were practicing medicine, the way that I was trained as a physician, wasn't addressing the context of these broader issues about trauma, about food insecurity, about housing insecurity, about our experiences of discrimination. And there was a decision point that I either had to leave healthcare and pursue another career or try to work within the healthcare system to change it. And it was at that point that I started to do a lot of research on the benefits of peer education around navigation, being able to demonstrate in a very scientifically rigorous manner that when families are working with community health workers, not only are you able to resolve unmet needs, but you can improve health outcomes and satisfaction on both the parts of the providers and the patients. During this journey, I was able to connect with Dr. Brooke Harris, who was the Surgeon General in the state of California. And she and I started to brainstorm together, what would it look like if we created a prospective pediatric ACEs screening tool in order to ask kids early on in life about trauma and adversity, and use that screening tool as a mechanism to have conversations with families to heal, prevent, and mitigate the effects of ACEs and toxic stress on our physiology and improve health outcomes. Which is how I started to work on the research and create, David, as you said, this PEARLS tool, which is now a tool. It's the Pediatric ACEs and related life event screen that is used in the state of California and reimbursed through Medi-Cal. It's also being used in other states across the country to change the way that we practice medicine to help to practice trauma-informed care, team-based medicine, and also ultimately it's about building relationships with families. And the earlier you can intervene, the better the outcomes are. So that's my journey about how I got here. And I have so much hope and optimism, despite the horribleness going on in the world right now, that we can continue to promote early relational health, because it is the response to trauma, right? It is showing up, it's being authentic. It is bringing our whole selves to the exam room, but also to bring our community so that we can network and refer families and really center the family voice in our experiences and the way that we practice medicine.
I mean, imagine how far we've come from trauma understanding to resiliency understanding, now to action and to hope and possibility. And Janice, I know you go on a long journey, not personally for sure, but you and I met as you were having deep conversations in Bridgeport. And maybe we could start there, move into the resiliency clinic, then talk about the baby bundle, open up that space ever further. Does that make sense?
Yeah, I think it does. And it flows so beautifully from Dana's experience. So you are my hero. we started this work in a collective impact context. And so that's Cradle to Career. And I joined them, I guess, embarrassingly 6 years ago. And they had already been working a little bit. This work takes a long time and it's hard. In any case, the initiative wasn't moving. And so when I came in, we looked at data, which I think is really important, and especially if it's community data, that is lived experience data as well as quantitative data. And we asked the question, starting with horrible high school graduation rates and going back down through 8th grade math and 3rd grade reading and school readiness. And the developmental psychologist in me kept saying, how young can we go? Can the data tell us where we had to focus? We got to 3 and the birth period. So this notion of children being on target at 3, I don't like the word readiness because that all children are different, but we do have milestones and we have some standard ways of thinking about this, thanks to the pediatric sector. That moved our community to begin to ask, what is going on for families? Dana, we look at Medicaid families, which is 7 out of 10 in Bridgeport. So that's been our population of focus. And after that was about the time that the resilience documentary was released, and we used it all over as a community gathering and conversation connecting point. I think we had more than 2,000 people across all kinds of venues coming to listen to that. And we realized ourselves and the people who came, the intrinsic and very powerful links between poverty and racial injustice and discrimination and all of that. Of course, that's not new, but we haven't focused nearly as well up to that point as we have. And that's, I think, one of the beauties of the resilience documentary and your work in all the California work. To take it to the baby bundle, the community said, we have to do something. This is horrible. We can't have 3 out of 4 kids not being in the range of on targetness. So we created a thought framework. It's called the Bridgeport Baby Bundle. It is not a program. It's not. I think 6 years later, I shouldn't have to say that. I still have to say it. It's not home visiting. It is 7 community strategies that the community thought and we thought all together, because I don't live in Bridgeport, down the road a bit, would allow us to have 3 act as a tipping point or an inflection point, so that when kids were 3, if they're on target, school readiness should be better, reading readiness, all that stuff should be better, which of course the science says is true. I'm glad to tell you when it's the right time what those strategies are, because they are dependent on an evidence base, but they're also dependent on deep community engagement and listening. And we did so much of that, and it was so hard. It was emotionally hard for everybody in that process. But that's our second core strategy, is you have to be deep in community, and what has to change has got to be identified from the community up. So We are working on all of those 7 strategies. They really became clear in 2018. So David, we, into our 3rd or 4th year, then COVID and no money, right? So it turns out that when you take a relationship base, you can do a lot of things that don't cost a lot of money. Eventually you need support for services. We engaged with the pediatricians, Dana, right off the bat in our 2 federally qualified health centers, and they have been amazing advocates. Sticking their head out of their office and getting out of the Medicaid constraints and beginning to think about what that relationship is between them and families and children and them and children, which is the heart, of course, of early relational health. So that's the story of Bridgeport in a nutshell. It is a framework. It's all in, and we're starting to see some things that are encouraging.
Janice, I just want to call out, you and I met because I was so excited about the fact you were talking about population health in a community when you were looking at Head Start data. And I just wanted to reemphasize what you said, that by age 3, the children coming into Head Start, unfortunately, only a quarter of them had expected developmental skills at that what we would expect at that point. But more importantly, you were keeping your eye on thinking about cohorts of babies toward improved well-being. That strategy is really, continues to be, I believe, critical.
So I would add one other word and then pass it to Dana to jump in. This notion of on-target development, it seems so straightforward to me, but really boggles people's mind. There's no measure. We don't know how to do this. There's not time in pediatric offices. And, we have to wait till kindergarten. No, no. So we got very clever and used Head Start data, as David said. They have data, and they have it for years. We've actually been looking at it in 3 periods, beginning in 2014, we looked in 2017, we looked in 2021. It's not the same as ages and stages or PEDS. It's a different kind of measure, but it was a good enough proxy, and most of the children were in that program. We are seeing, David, inching forward, better readiness levels, proportions of children. When COVID is really gone, there'll be 1,000 children out of the 2,000 3-year-olds. So half the kids in Bridgeport will be going there. And even with small numbers, we're seeing in physical development and in language development that people are doing better in the sense of meeting the expectations of the skills and.
Whoops. I just lost Janice. I think she'll be back. So Dana, you want to react and add in?
I do want to react because I was jotting notes as Janice was speaking, and there was something that really struck me. And what Janice said is that she said that listening was hard. Like the deep listening that was required was hard. And I want to dive into that a little bit more when Janice rejoins us about how to do that and how to sort of navigate the spaces and to make sure that we are practicing principles of equity in how we listen and how we are accountable to the family narratives and the voice and the creation of the programs and the initiatives that we are part of. So if I could, Janice, I had just asked a question because it struck me, and it is exactly where my mind is these days. And the question was about a comment that you made about how listening and incorporating the family voice required really deep skills and was hard. And I'm wondering if we could stay there and reflect on the process that you went through and that you are going through to incorporate that family voice, and what were the pain points and how do you reconcile them or at least acknowledge them?
Sure. So the answer is an interesting one because it's a threaded group of things, none of them sufficient probably on their own, but all of them together being more than their additive value. We were working out of the United Way as a backbone agency. And in our state, in our city, the United Way was viewed by families in the community, largely families of color, as the White Castle on the hill. So that'll give you an idea of how the community viewed this particular structure. So we had to go about building relationships with just people. We did that through lots of opportunities to listen. We used resilience completely all the time because it was just a thing we could do together, and then we could talk. But the United Way hired, they engaged what they called community messengers, 15 people from the community who they didn't pay to bring in the community voice. Well, we fixed that right off. I'm sorry, I seem to have a helicopter outside. That is very strange.
We're okay now. We're good.
Yeah, okay. So part of our model was to actually hire them, and they are now engaged with us, and they go back into the community and bring community voice to us. In addition, we've used a process of community organizations where families converge, actually hosting conversations to bring community voice forward. We just got a grant to have community involved in building a database. So we use a lot of different kinds of methods. I do think the most effective was when we worked in a lot of our Black churches and we showed resilience, and really Alice and I were the only white faces in the whole place. And there was a lot of crying, and there was a lot of holding and touching. So we've done everything from 50,000 feet to 3 feet on the ground together. There's more to do, but that's the strategy that felt most real to us. Our rule is start with the heart. I mean, it sounds corny, but that's where relationships have to be. So that is what we've used, using all these different tactics or tools. And the messengers are unbelievable. I hope sometime to share them with you. And two other things. Actually, we've been building a doula partnership with doulas that is growing like crazy, and that is in the community. I think the FBI is coming for me. This is very weird. And also community health workers are now essential to the new work we're doing around universal home visiting. So of the community, trusted messengers, and we are calling these folks wellness navigators.
And they're leaning in around the perinatal space.
Pardon me?
They're leaning in around the perinatal space for
yes, we absolutely pregnancy and perinatal, absolutely. And
really
continue with the faith communities, because really services are good, but supports are usually come from places like that. So that's not a simple answer, and there was no one answer, but there have been a bunch of strategies that we've been using, and they seem to be working.
So thank you for that response. And it is a challenge. So I just want to throw out there some ways that we've been incorporating family voice into the work in California. So my home is within the University of California, San Francisco, at our UCSF Benioff Children's Hospital Oakland Clinic. As part of being an FQHC, one of the mandates is that you have a board, a community advisory board, and that community advisory board, it has to have members of the community from all sectors on the board. Our institutional review board broadly for research, also it's mandated that there are community members. More recently, both Dr. Willis and I were part of a screening initiative network through the American Academy of Pediatrics. And one of the really novel aspects of that work was that it was highly recommended that there was a family partner as part of each of the teams that were spread across many different states. And it was challenging. Some practices went through that entire initiative without being able to find a parent voice. And those that found them often struggled with how to incorporate that experience in ways that made the family feel like their voice was heard and that they had a platform that could be leveraged. One of the exciting ways that we are integrating family voice is through the University of California, San Francisco, and UCLA ACEs Aware Network, which is a new network where the ACEs Aware initiative that was housed within our Department of Healthcare Services and the California Office of Surgeon General has now moved to have an academic anchor within UCLA and UCSF. And we are building out, I'm so excited, a statewide community council that is going to be facilitated by community members community members are going to be paid for their time, and their influence is going to be in all sectors of the work that's happening. And so it's going to influence the type of evidence and evaluations that we do. It will influence the training and the workforce development. It also will influence the ways that we are implementing ACEs screening and response in clinics and communities. And so it is forming, right? Like, we are saying that we're part of a movement, and I'm excited that the Office of Surgeon General and the Department of Healthcare Services is willing to fund this really broad community council that will be ranging from across the state and really multidisciplinary. So hopefully I can talk about that work and sort of bring the lead of that work onto one of our Willis and Friends in the future.
That's right. Could I jump on that then, just in the dialogue that we're having, because you reminded me of a couple pieces that had not come to my mind, and they mirror some of what you're saying. Now, Connecticut is not as big as Orange County, right? So we should be able to do this work really well. And we have lots of resources as a state, but they're not evenly distributed in any kind of way. Anyway, 4 things that mirror what you have said that I did not mention. The first is that the Office for Early Childhood, which is turning out to be very important in all of this work and finding its own, it's got wind under its wings now and some money. They just created a family council. And it's all families, and they call it a parent council, but it is a family council. And that group of people meets monthly, and they input to the commissioner level folks what's really going on. I like that. I suspect the first meetings were awkward, but when people find their voice, they have found their voice. The second is that we did what you did too on the ACEs front. We co-chair the state. Jeez. I keep hitting my computer, so I should put knitting needles or something.
You're doing great.
No, I lost you once completely and had to log in. On the statewide adversity to resilience, trauma to resilience, we are co-chairing that, and the head of our doula association is one of the leaders. Wow. That's been stunning. Here's another one, 2 other ones that I love, and one is really unlikely. We now have 3 family members on the board of directors of the United Way. Now that is, you're at the power base then, and that's been hard, really hard. The last one is that doulas, which are family members themselves, right? And they work in family. They actually did a multi-month training of all of our OBs in Bridgeport on racial justice. And they have stories of implicit bias that, we have to hear. I mean, they break your heart stories, but they actually did a formal training with the OBs, and together it was the most amazing experience. So if we put what we're both doing together, there are really a lot of ways to begin to encourage, I hate the word empower, encourage families to feel like they have a voice and they have a role, and someone will listen and something will be different.
So Janice, let me lean in a little bit. First of all, you called out something I've thought a lot about and actually heard from parent leaders, and that's the rule of 3. You have the rule of 5, but the rule of 3, that always think about 3 to 4 parents together as a team at a table, so that you don't have a token, because it's work. It's really hard work. And then also supporting them.
Absolutely.
Their element and their voice. That's the first thing I thought of. Second thing I thought about, both of you, we're talking about everything's local, right? And how do you bring family voice into practices and local experience so that then the transformational social justice efforts become into the center of the clinical experience? And we've experienced some of that challenge in Washington State. We're working at it, but bringing, family voice partnership into clinic space with people, not the FQHCs, which are further along, and yet I'm sure the dialogues are still important, but the primary care practices where, again, the rule of 3, where you can have authentic conversation of what works and doesn't work over time, it strikes me as another part of the important critical work.
Yeah. But my response to that, and Dana's will be much more informed, is that requires us to think about pediatrics in the way that you have both always thought about pediatrics, and not the way that we necessarily deliver pediatrics, and especially in non-federally qualified health centers. So I think that's a hard one to do. I think there are intermediate steps. We have Reach Out and Read and a bunch of other sort of family-oriented programs in pediatric offices already, and we're showing our bundle, the baby bundle, and other kinds of information in pediatric practices. You know, like we bought them televisions 2 years ago so they could run the baby bundle videos just instead of fish, right? And so those things we're doing, but the time demands are very potent for pediatricians. And that may just be an excuse for I'm not comfortable, but it does seem that the way that we pay for this service on the part of pediatricians makes it hard for the time to be taken away as a factor.
Yeah, that's right. That's a big challenge. We are paid as providers based upon the revenue that we generate from the number of visits that we see and how we bill for those visits. So being able to do this type of work requires protected time, which requires funding and the approval from senior leadership at your institution that there's an academic value add to the work that relationship building brings, which is what we are trying to do. And this is now getting off on another tangent, but as part of the work of CSSP, we are very focused on workforce development and what are the critical elements that are necessary to build safe, stable, nurturing relationships, and working with academic pediatric primary care centers to be able to infuse the EHR, early relational health curriculum, into medical school and residency education, along with that parent voice to let us know if we're on the right track.
Yeah.
I do really want us in this conversation, because we have you here, Janice, to talk more about the 7 strategies and how you mentioned that there's evidence base for each of the strategies. Can we dive in more to that?
Yes, and so let me say it more correctly than I said it. I can go through the 7 strategies. They're perfectly logical. So it doesn't, it's not going to stress anybody out to have to sort of think our way through this. And 7 is the number in your head, right? We know you can hold 7 things. So we don't have 10 strategies, right? It's just taking advantage of what we know. I will just go through them sequentially because one builds on the other. The first is that the community knew we don't have enough services. We didn't. And we have a paucity of things that we know help families. So the first strategy is to take evidence-based and evidence-informed programs and expand them where they feel relevant to the community in this prenatal to 3 space, and take them as a bundle. So we have a series of strategies that are very light touch. And then we have other strategies that are random control trial in early literacy, and we have so we have early literacy, we have home visiting, universal and targeted, and a series of other kinds of actual program, including childcare, which is really important. That's the first core strategy. We need to have a better system of supports. The second one is that you can't build any of this without deep community engagement and stimulating communities to find answers themselves. For us, that was the sort of pushing on evidence-based strategies, which I love as a researcher, and I hate because it sort of squashes innovation. So if a legislature wants to see an evidence-based strategy, they're not going to fund innovations. And in the relationship context, well, in Connecticut, so that's only my base of experience. So how do we stimulate community to build some answers for themselves that has a lot to do with their social network and their social capital and how they engage with each other, which is where they turn for help anyway. So that second strategy for us was really important. Be in the community, actually bring the community into this framework, and then make sure that you don't squash innovation, so that there are little investment funds that you can, try things out. The third one says, this is, I guess, my age, and I know I push this one, that it's not enough to do 1 and 2. Unless there is policy advocacy, even political small p advocacy that decision makers and funders can touch, you'll end up with just spotty bits of pieces. So we really encourage people to take to the streets and talk to their legislators. We had a baby. September 9th is baby day in Bridgeport. And our vision before we had, strolling thunder from 0 to 3 was that, we'd have a couple hundred or 1,000 moms with their baby strollers going down Main Street. We'd shut the street down and we'd all come out. That is still possible, but that's number 3, right? There has to be action. The 4th one says, whatever we do in our engagement that involves services, it has to be trauma informed and resilience focused. So the core practice of delivery has to change in the ways that you've described it's changing. The 5th is that a community can't serve its families unless the community agencies are healthy. And that gets to the notion of how do we pay some of our people who serve. So doulas don't get paid nearly what they should. Community health workers are underpaid. Childcare is underpaid. Organizations are under stress. And that for us was important. We didn't want to leave out the people who serve all of us. So that was the 5th one. The 6th one is you have to have data. Please, please, data. I mean, you have to keep track of what you're doing because what you measure is what is important to you. And the last one says somebody's got to fund this. So we took a very broad view because it's a community resilience project. We didn't just look at funding a service. We have looked at federal funds across the board. We've looked at high wealth donors. We have a pretty comprehensive funding strategy because it's about community change. What we didn't articulate were in the strategies, which I think was a mistake, but I think we found where it fits. We always take strategic communications as a last thing. Let me tell you what I did. As opposed to, let's think about it as a tool and a strategy that helps bring people along together. And I wish we had had a specific one around strategic communications, but we do it in number 2 and number 3. So that's important. The other thing, Dana, that has emerged is that we have made up a toolkit of evidence-informed design. So how do you do impact analyses? What is the best learning around racial justice? How do we have these conversations? There are tools all over the place, and communities don't have someone who can say they're here, try it. So Pearl is there. It's here. Let's look at what it can be. So we have in our design, a box, and it says filters and tools. And then the other part of this that I am so excited about, we learned that this doesn't just have to be about babies, that our framework didn't talk about the economic health of families. It didn't talk all by itself about housing and food needs and diapers. So we are in the process of actually building those pieces back in as they need to be for families to have solid, positive relationship with their babies. So you guys are ahead of us there. And I think that's been a weakness, but we're fixing it. So those are the 7 strategies and some of the filters and tools. Did that make sense as an outside listener?
And so I was trying to do deep listening as you were saying. And so I think I wrote down the 7, and maybe I can just repeat them. I'm such an auditory learner to make sure that I got them right, friend, for everyone in the audience. That the first is that find the programs that work and scale them, right? We know that there are programs, like you said, around literacy that work. So don't reinvent the wheel. The second was be in community and look for innovations and don't squash them. Oftentimes in academics or politics, we say that everything needs to be evidence-based, which I do believe in, but sometimes it can take decades to build the evidence. So don't squash the innovation. The third is that take 1 and 2 seriously and advocate and act, right? Get out on the streets. The fourth is that we must be trauma-informed and really resiliency focused in all of our work, in all of our clinical work. The fifth is that agencies need to be healthy. They need to get paid for their services, which is a part of equity and parity. The sixth is that data, please, more and more data, evidence and evaluation, collect the information that you need so that you can demonstrate evidence. And then the seventh is have broad funding strategies and networks of funders.
Yeah, and the other piece which is where we started, and I will say we didn't start here, but we got here pretty quick. That is really the issue of equity and justice. I mean, we have hugely disparate outcomes, and so we try to think through these strategies using that as a filter in every single one, which of course goes to the community voice piece that we've been having. So while it's explicit in our little diagram, it wasn't explicit in what I said. So I want to say that has just taken that, dealing with issues of racial and health and educational and economic injustice and disparity, coupled with the community voice piece, real engagement, that's the platform on which the framework sits.
And Janice, is there a backbone structure that drives this or holds it or keeps mindful? How does that work?
We have the United Way as our backbone agency, and we could use a lot more help. So it's a very small staff, and 2 or 3 people, really 2 or 3 people, and a couple of us as consultants. I feel like as we have grown, we want to look at alternative backbone strategies, or we may actually want to become our own. That would not be inconceivable to me, that this work could stand on its own. So yes, we do, and it has been useful, but there are ways to make the backbone agency more useful, and I do view it as essential. So somebody has to help and support and provide the office home, if not conceptual home for this work.
And Janice, how do you keep the energy, the excitement, the determination, the passion over 4 years, 5 years, 6 years? Because it's long work.
Yeah.
And how do you think about that? So we hit COVID. It just knocked many people to their knees. What have you witnessed about how the baby bundle movement, Bridgeport Prosperous, how it's kept itself alive, but also enthusiastic and also hopeful, and also, what are your thoughts about that?
Yeah, I'm thinking about this, David, sequentially, because this 5 or 6 years has been impacted by lots of things not under our control. Exactly. And to begin with, we just knew we had a data point that nobody could stand, and it was wrong. It was morally wrong and everything else wrong. So that's what drove us to begin with, just to learn what we had, how people felt about it. The actual framework of the framework that we call the baby bundle framework, the diagram that shows it, that emerged after about 1.5 years or 2 years. We did a series of public events where we summarized all the research in the world for each one of these strategies on a page. That's hard for me, right? You can tell. But so we did all of those things. And then we were making very strong headways through the health door. We opted for the health door instead of the human services door because it seemed to us that well-being sits there. And then COVID hit. So we have Zoomed ourselves to death on this. And people are now beginning to come together. The relationships held. We built the relationships first. The structures were a little questionable sometime, but the relationships held. And so when we came out of COVID, now writing this huge pairing of community health workers with visiting nurses in terms of universal home visiting. The team is together. Families are at the table. We have 2 parents represented us at the table. So the relationships held. And now that we can come out of hiding and be with each other again, the structure's fine. It needs to be adjusted. And I guess that's a long way of saying, we just kept at it, and every time an adversity hit, we found a crack in the mountain and went through. Not enough celebration, and we could have used more people. This is very time intensive, even when you have 6 or 7 rings of people helping. People are still excited; they still believe. And then, of course, when someone says, well, you could have $4 million if you can write a halfway decent grant, then suddenly you see a real tangible moving to scale in one of the very important core strategies. And that's got people really excited. So
one other thought, then Dana, to you, but Janice, one of the messages that I took away from the resilience film and the whole movement is that hope springs out of the relationships and the authentic storytelling and the capacity of the human spirit to find future possibility, that becomes really critical as babies are born. And what I think I learned from Jeff Kennedy was, when you infuse that, the baby colleges and the community sense of we're going to do better, that determination that becomes bigger than itself around next generation, it starts to become infectious of we can find a path forward. Is that accurate? Is it, are you witnessing that? How are you thinking about that? I'm thinking again, the 2,000 babies born a year, right?
Yes.
2,000 babies a year. And in 3 years, you got data.
That's what I love about this. Scary too. I think when I called you, David, I said, this isn't a 20-year program.
Nope.
We have to know something in 3 years once we are launched, right? You sort of launch in dribs and drabs. And so the question is, when do you have critical impact capacity? But yes, Can I reflect on your question just for a minute and have Dana jump in, and then I promise to come back and answer. I want to think about it for a minute.
Sure.
I have found that as a workforce, we as providers, particularly primary care providers who have been considered frontline for the last 2.5 years, we have been exhausted. And what also is simultaneously true is everything that you just said, walking into the room and seeing a new baby, it is impossible not to be happy and feel joy and to feel inspired. And so this, the work that we're doing, it is inherently full of love. Right? Yes. And as long as there is love, there is hope.
Well, and that goes to my start with the heart, which some people in our operational hub thought was nuts, right? There comes this squeaky lady and she wants to talk about how you're feeling. But I do believe that's right. I do believe, David, that goes to storytelling. The power of that was evident to me in two contexts. The first was using resilience and then having an hour or two afterward to tell our stories. We didn't tell too many stories, the two white ladies in the room. I told my story eventually when I got brave enough, because people had similar experiences and we were able to really bond together around both the pain and the growth that we had done. So I think storytelling is essential. I think storytelling without the ability to capture it in some visual way or some written way and couple it with data, right? I think that makes it even more powerful. The other piece of the storytelling part of this was just the immensely emotional experience of being in churches of color, which are the predominant. We have 128 churches and temples and mosques in this little city, which is a lot, like almost every corner. And we hadn't tapped them. So using the documentary, but now we go back and talk about these other things. That's the time for people to tell their stories, and then for us to figure out together what can we do to change the metric that started it all. So I think you're right, but I think it has to grow from that too. I mean, there has to be, it can't just be people come back every week and tell their stories. They have to see something that represents change and transformation and love. Dana, absolutely love. A lot of listening. We cried together. Really, we did.
Amazing. And Janice, how, and Dana too, how, we've come together on this relational health frame, the sense of foundational relationships, the sense of hope and love that surrounds next generation. How are you, we talk about this as being a movement. I really focus intentionally on the relational power that's critically important for the community, for families, for certainly around infants and young children and toddlers. Is that understood deep in Bridgeport? Do people talk about the criticalness of those earliest relationships for the future? I mean, what are you witnessing?
They don't use the language that you and I use to start with. And it's taken us as a collective quite a while to figure out what that really means, right? That it's not some thing that's just laid on top. Well, it is a strategy and a framework, and it is not laid on top. It just allows us to have these conversations systematically. I think the answer to that honestly lies in Dana's observation that when you look at a baby and when you know that that baby's able to focus And when you know that almost instantly there is a relationship growing between you, and that it matters what you do because the baby receives it, that babies can hear things in utero. I mean, people haven't known that knowledge, but it does. Well, seeing babies releases all of the positive biochemicals we have in our system, and we should take advantage of that. So I think, honestly, it has to be really grounded in these little creatures that we're engaged with. Not a very good answer, but I think you're
No,
right.
the science is there, but the human knowing of love that goes in that eye-to-eye contact moment that's felt,
Yeah.
but also others witnessing the beauty of it shared,
Yes.
and the narrative that happens there with the doulas that are talking about, the community health workers, or the nanny or the granny or the others that said, think about the future here, honey. This little baby's going to have an incredible positive future. Not to be a Pollyanna, but to be intentional, I think is really important.
I think, too, to just let yourself feel. I mean, there isn't anybody I know that can look at a puppy or a baby and not feel this thing. And so calling that out, what this thing is, and that it is, we all do it. It's not, we don't have to learn to do it unless we have learned other behaviors early on, which of course is where the trauma comes from. I just think the natural nature of this and using pictures. Honestly, I never gave a speech in the first beginning of this when I didn't use baby pictures and puppy pictures. Why? Because I knew exactly what it did for people, and then they were mine, right? Then I owned the conversation that would happen with the rest of the presentation. That's shameless. But the science.
Janice, I did the same thing with video. The beauty of a relational experience shared, because it just pulls you right into a moment.
One other thing, David, that I would love to hear Dana talk about. You and I presented on this together in one of our forays into home visiting. Remember the thing we did about Grandparents Matter?
Oh,
so
yes.
I've done childcare myself for my own kids and other kids. And what we found in Bridgeport, that the national data, which says, 30 or 40% of babies are being raised for some substantive part of the day or in whole by their grandparents or their aunties or something. And we have focused on the mom and the baby, and that is essential. But if this baby is spending 8 hours with someone else and we're not attending to that part of relationship building, then we're missing 8 hours of a baby's awake day. So we have really been looking at how other extended family members fit into this process, right, of building relationships. And that makes it more complicated because everybody brings their own self into it. But we just can't forget that part. The one other thing I learned in a project with Andy Casey, we were looking at young parents and where they only wanted to know about young moms, where they got their information. I wanted to know about young dads because my biology, when we still had sex education, said it took two people to tango, right? And dads weren't a part of this, and they have been sort of an afterthought. They get their information based on their recounts from their mothers. So another reason for thinking about the intergenerational power and possibilities of this work, not to mention grown-ups vote. So, community strategy number 3. So you just have to be open to really understanding the family context from your eyes and your heart, and then open to the heart and the stories of other people.
I so agree. We're coming to the end of our amazing hour. And I just wonder if each of you might have just a few closing thoughts. We have about maybe a minute and a half for each of you. Dana, do you want to go first? Then Janice, and we'll finish up.
I do want to go first, and I have to tell you that my closing remarks are going to be a little bit unexpected, but it has to relate to what the two of you were just saying about these pictures of babies and puppies. And so I am a single mom. I have 3 boys. COVID has been particularly challenging in terms of developing their social networks and allowing them to experience relationships in terms of little league or football or just hanging out with friends. And so we're getting a little puppy this week.
Oh,
Our puppy's name is Olive, and she's about 6 months old. And we are currently preparing for her arrival. So I'm very excited about that.
pictures. Need
I
to be.
will put pictures up. Yeah.
And then you can just put them in your presentations, and you won't have to worry about, legal, intellectual property or anything.
Exactly. That's so good, Dana.
But my academic hat in preparation for this talk to close was that the work on early relational health is so very important. And my goal over the next 3 to 5 years is to continue to find ways to sustain the operational nature of trauma-informed teams such that we can move away from philanthropy in order for institutions to realize that bringing community into the walls of ivory towers is going to improve the health outcomes and the satisfaction levels across the board, and that we cannot continue to devalue the work of doulas or community health workers or health educators by saying that they're marginalized, they're only paid for by philanthropy. They really need to be part of operational fiscal budgets.
Here, and let's continue that conversation over time because it's right on. It's the future. That's where we're heading. And Janice, quick closing remark, and then we'll close our conversation.
3 words. What she said.
Including about getting the puppy.
Well, I have to pass on that one. But.
Yeah, well, Dana, we got a puppy coming in our lives. We've got one coming in October. So what the heck.
Oh, all right.
As well as a new granddaughter, and so it's all good.
David, this conversation, as so many that I've been privileged to listen in on and sometimes talk a little too much, are terribly positively supportive for people like us who are in the field, where sometimes it feels like you're pushing water up a hill. So we need to take care of ourselves and keep our own hearts alive and our own voices active in the times we're in. So that's cheating, right? I did my 3 words and then I said some more. Thank you so much.
It's a privilege, and I share that this is, the friendships matter, the connections of heart matter, our stories together matter. So thanks for your time. You see you around. Thanks everybody for the audience. And we'll be meeting again August 17th with our next Willis Friends. Thanks so much.
Thank you.